Hey everyone, I'm Dr. Jeff Yu, a real board-certified ER doctor in both the USA and Canada, and today I'm going to be reviewing the Pitt Season 2, Episode 3. Let's get to it.
Hard to assess pupils.
Hard to assess anything.
Yeah. Wait till after he's sedated.
Can of olanzapine?
That'll take 15 minutes to kick in. 5 intraperidol, put them down at 5.
So what they're talking about is giving different antipsychotics. And olanzapine is a non-typical antipsychotic, which is quite effective, but takes quite a bit of time to kick in. Dr. Robbie is suggesting that he gives haloperidol, which is a sedating antipsychotic, which is very commonly used in the ER. So typically we would give 5 milligrams of Haldol, either IM or IV, combined with a benzodiazepine like midazolam or lorazepam. So the other thing that we can sometimes do if he doesn't respond to sedating antipsychotics is we can give an intramuscular injection of ketamine, which comes on quite quickly. Someone that is that diaphoretic or sweaty, who's flailing, is going to be at really high risk of hurting others and also at risk of rhabdomyolysis, like muscle breakdown from severe agitation. The things that I would be wanting to do is check his temperature to make sure that he's not hyperthermic and getting his agitation under control as quickly as possible. Like typically within 5 to 10 minutes, you want to get this patient under control.
There's the first barb out. All right, Shavati, you're up.
So what they're doing is they're removing the barbs from a taser. So what most people don't realize is that when someone is tased, the way that it happens is the taser gun shoots out usually 2 barbs that hook into people's skin, just kind of like fish hooks. And then the electricity is delivered through these barbs. I see quite a few people that are brought in by police officers where I need to remove the barbs from these tasers as well. And typically what we'd be doing is an ECG to make sure that there's no electrical abnormalities to the heart, because that's one of the complications to being tased.
Tox screen negative for cocaine, amphetamines, marijuana, PCP, benzos, and opioids.
So this is essentially ruling out substance-induced psychosis. So we would start to think about a more primary psychiatric illness like a new psychotic break or schizophrenia, bipolar mania. These are the things that I would be thinking about in this scenario if the tox screen has been negative for all of these other substances.
Sorry, Miss Graham. I just saw the ASO note in your chart. This is Lindsay. We'll bring you back as soon as possible. Stay with her.
So this is quite common in the emergency department as well. People who are hearing impaired who you need to use American Sign Language or ASL interpreters to communicate with them. We typically don't have in-person ASL interpreters in the ER, but what we do have are video interpreters where you use a little iPad, wheel it to the bedside, and then a video comes on with someone who can actually do ASL interpretation. Sometimes if that doesn't work, what I often do is I pull my phone out and use Google Translate and use speech to text and I get them to read my questions and I get them to respond by speaking to me, or I get them to type in their responses.
BP 95 over 67.
Seems a little on the low side.
It is. Have you ever had low blood pressure in the past?
No, sir. My blood pressure is always high.
Okay, so that's a major red flag. If someone's blood pressure is usually quite high and they come in with a blood pressure of 95 on 60, that would raise a lot of alarm bells. I'd want to know if there's any signs of infection. I'd want to know what kind of medications they're on. Judging from this screenshot over here, it looks like his heart rate is 56. So that points away from infection and would point more towards kind of like a beta blocker overdose, something that would slow your heart rate and your blood pressure down.
Playing family pharmacist.
Pulling meds is how we've always done it. You put everything in a big pile in the middle of the table.
Well, look where that got us now.
No, I'm going to jump in here and echo that sharing meds which haven't been prescribed to you is actually a real big no-no.
Absolutely. This is something that we sometimes see between spouses or siblings, people sharing medications like prescription pain medications, antihypertensive medications, or blood pressure medications. And the biggest reason that we recommend against it is because people respond very differently, even to small doses of these medications, which is why oftentimes when we're prescribing medications, we'll start low and go slow when we're titrating it, because we want to see how someone responds to it before we just toss them onto this medication.
Whatever little round pill you took, sir, has caused your heart rate and blood pressure to drop so low you're at risk of fainting, falling, or having a serious injury.
So the thing that I'd be really worried about with a low heart rate at 56 with a low blood pressure is a beta blocker overdose or a calcium channel blocker overdose like diltiazem.
Okay. Atorvastatin.
Atorvastatin is a medication for high cholesterol.
Simvastatin. Ezetimibe. Those are all high cholesterol medications. Can you go to the right? Lisinopril.
So high blood pressure med.
Losartan. Propranolol.
Wait,
Propranolol is the culprit. Propranolol lowers your blood pressure and your heart rate.
That's it. Wendy's pile. Yellowish bottle, little round blue pills, just like I said.
Propranolol is a beta blocker,
Bingo,
what I was
little
telling you
lady.
before.
Okay, yeah, well, this makes a lot of sense now. How many pills did you take?
Oh, I think 4, maybe 5.
That's a really big dose.
That is a lot. Okay.
Got full stomach, mind you.
Well, the good news is it has a short half-life.
I don't like going to doctors.
Well, that makes 2 of us. We all need help from time to time. Think maybe we could arrange for some ongoing care?
This is quite common as well. People who are unhoused often also struggle from mental illness or a substance misuse. And oftentimes there are a lot of distrust that exists between these patients and healthcare workers. So, we try our very best to develop strong rapport and get them to trust us. I often give them a sandwich and juice to make sure that they're fed because, a lot of these people have gone many, many hours or even days without eating or drinking. Another common thing that I do is get them clean and dry socks because a lot of these people suffer from trench foot because they've been walking around in cold and wet shoes and socks.
Use the system. That's what it's there for. Buddy of mine, Dylan, knows all the angles, even works the occasional miracle. You think maybe I could have him stop by?
So what she's doing is she's getting the social worker to come and chat with the patient. I do this all the time in my ER as well. The social worker can help connect these patients with outpatient resources, like different clinics that they can go to for repeat IV antibiotics for skin and soft tissue infections. The other thing that they can do is they can actually call around to the different shelters in the city to see which shelters have beds and try to reserve a bed so that the patient can leave from the ER and go straight there to have a bed to sleep in for that night.
Great. How about a sandwich?
Yeah.
Sandwich.
Yes, please.
There we go.
There's some flags, bruising in various stages of healing.
Bruising at various stages of healing is one of the biggest red flags that we see in non-accidental injury. It means that they've been battered and beaten at multiple different times throughout the last few weeks.
We'll find out more when Dad shows up.
Yep, if he shows up.
Okay, I got it now. 1, 2, 3.
Daddy, you okay?
Oh, baby, what's going on, huh?
My chin's broken, my chin got cut.
Oh, no.
So this is quite reassuring. The girl looks happy to see her father. She's not scared or intimidated by his presence, and he's quite warm and affectionate towards her. So this is all quite reassuring signs that would point away from non-accidental injury.
I'm sorry, are you fucking kidding me? Where are you going with this? Are you saying that I hurt my daughter?
Mr. Connors, no.
Oh, no. Gina!
So I've seen this kind of reaction as well. People can take this quite defensively. So, I would frame this questioning as like, these are just standard questions. We're not threatening or implying anything. We just want to know how she got these injuries.
Talk about me and my daughter.
Who the fuck?
Yeah, that's what I'm asking. Hey, big man, take one more fucking step.
Hey, that's enough. You
So this is a major red flag. Just seeing him lose his temper and his cool in the middle of the ER, swearing at his girlfriend, also needing security there to de-escalate the situation. This is like a major red flag. I would 100% be suspicious of the father.
Oh,
Hey, everybody, back the fuck up!
Stop! Kylie's platelets are only 9,000.
What does that mean?
Okay, so the platelets are very, very low. This would possibly point towards hematologic cause like ITP or idiopathic or immunologic thrombocytopenia as a potential cause of her blood or her bruising and the blood in the urine. So this is one of the things that can sometimes masquerade as non-accidental injury.
It's not what we thought. It's probably ITP.
ITP, there it is.
What the hell is ITP?
So ITP is kind of like an autoimmune condition where the body attacks the platelets and starts eating it all up. Oftentimes we'll treat this with a medication called IVIG that kind of settles the immune response down. I guess I was totally wrong on the father.
Your little girl was ITP?
Go figure. Nothing like a zebra to kickstart your morning.
So we call rare diagnoses zebras. The common saying in medicine is if you hear hooves clacking, think horses, not zebras. That's where this saying comes from. It's a very common saying in medicine.
Know what idiopathic means?
That we don't know the exact cause.
Means the patient is
Pathetic and the doctor is an idiot. So this is a very, very common saying in medicine as well.
And I said something stupid and you just fucking let me finish.
You are finished!
So this is quite realistic. This is one of the aspects of emergency medicine that makes it quite interesting, but also very unpredictable. You're just seeing all of the raw human emotions spill out at bedsides and the hallways. And it's important to realize that you're always meeting patients often on the worst days of their lives.
Well, happy fucking 4th of July.
Yeah, happy Independence Day.
It's a tumor. Is it what made me fall?
Probably is.
Yeah, possibly. We'd like to keep you here and treat with dexamethasone.
Dexamethasone is a steroid that helps to decrease the inflammation and swelling from that tumor.
Just a steroid to take down the swelling, and then we'll need a brain biopsy to know exactly what it is.
Yeah.
A CT-guided stereotactical biopsy with a blunt, thin needle.
That's not something that we would do in the emergency department. Obviously, this would be referred out to neurosurgery, and they would do that under a very, very controlled surgical technique using microscopes and either go through the nose or make a small burr hole, which is a small hole in the skull, to actually take that biopsy.
I'm sorry that they called you. I never updated the form, I guess.
No, it's okay.
Well, you didn't have to come.
But I did.
You know, this is a heartwarming moment, but I would be taking this opportunity to clarify with the patient who would be his substitute decision maker if he does become confused again, because in the first 2 episodes, it seemed like his confusion was kind of fluctuating. So if he does deteriorate, I'd want to clarify with him while he is lucid and competent whether his wife would be the best person to make decisions for him if he were to deteriorate.
Could that mass have been there for a while and only recently got worse?
Yes.
Could it be responsible for how much he changed?
Yeah, absolutely. I've seen people with bad frontal bleeds and tumors. My wife worked on the stroke neuro ward where she saw a lot of patients with really bad frontal lobe traumatic brain injuries. And one of the defining features to damage to the frontal lobe is you lose all of your inhibitions. So it's really sad because these people will often do very inappropriate things like removing their clothes, sometimes, doing inappropriate things like masturbation in front of other patients and other healthcare professionals. Sometimes they'll make sexual advances to other people. Sometimes they'll be very verbally aggressive and lose their temper for very minor things. It's one of the saddest things with brain lesions.
He was getting into fights with strangers.
Oh, yeah.
Hello, Mrs. Kovalenko. My name is Dr. Michael Rabinovich. Everybody calls me Dr. Robbie.
Rabinovich, Jewish?
You guessed it. And I see that you are here today for a burn.
So the one thing that I'm noting about Dr. Robbie is that he's staring at the screen, logging in while talking to the patient. Typically, like with bedside manner, I usually prefer that you look in the patient's eyes and speak to them directly and do all the charting afterwards. Just it helps to build rapport.
Ooh. What did you put on this?
Ooh. So those are second-degree burns. You can see that it's already blistered and de-roofed. At least second-degree burns. I'd want to touch it to see if she has sensation, to see how leathery that skin is, to see if there's actually a full thickness or a third-degree burn.
I'm sorry, did you say honey?
You think honey's funny? Works like a charm.
If the honey is medical grade and the burns are not too bad, honey actually does have some antibacterial and anti-inflammatory properties.
That's true, actually. So there is a difference between medical grade honey and kitchen honey. So medical grade honey is essentially regulated and sterilized, just like any other kind of medical wound care product, like ointment or cream. There are evidence to actually suggest that it has antibacterial properties, anti-inflammatory properties, and can be used for lower grade burns, like first and second degree burns, to help with healing. You should not be applying regular, kitchen honey that you would spread on your toast on wounds.
Not to worry. We're going to have you patched up and home in time for dinner and fireworks.
No. No more fireworks.
Fireworks are seriously, we see so many firework injuries, it's terrible. And what people don't actually realize is that fireworks are explosives. They're literally like small little bombs that people are using. So I've seen people's hands and fingers being blown off from fireworks. It's really terrible.
To the synagogue when the shooting started.
So, this is really sad. I think especially in America, there are so many shootings that happen. And I think fireworks are definitely triggering for a lot of people because it reminds them of gunshots that have happened in their past. So, it's just, I think, one of the sad things that's unique to America.
Hey, tell them.
Me and my sister are making bracelets, and I put beads up my nose.
How many?
So we see this quite often with kids as well. Kids that put carrots, beads, different toys up their noses. I had one kid recently that put the pink eraser from a pencil up his nose as well. And the way that we would typically treat this is with what we call a mother's kiss, where you obstruct the other nose that doesn't have the foreign body in it, and then you get the mom or parent to blow mouth to mouth a full breath, and it usually shoots out like a rocket.
One on each side.
I gotta ask, why do you stick them up there? See how many will fit?
To shoot them out like rockets.
Oh my God, I said that.
But I breathed in, and they went deeper.
Red bead below the inferior turbinate.
I got a blue one. Afrin, benzocaine, cas extractor.
Yep.
So benzocaine is a numbing agent that we would insert into the nose to make it more comfortable so that you're not feeling pain when we use a CATS extractor, which is essentially a device that attaches to a syringe. You push air into it to inflate a balloon past the object, and then you pull it backwards to remove the object.
Got it.
Duante, what are you doing in there?
Oh, cool. I didn't realize that some ERs have these like 3D virtual reality things, but this would be a great addition to any ER, and I feel like I should probably speak to our department and see if we can get these. That's a great idea.
Son?
I'm a rabbit.
And there's this one about fatherhood. Really stuck with me.
Nice.
One red bead.
Satisfying.
Yeah. So I will take all the wisdom I can.
Love it.
Blue bead out.
Motorcycle ran the light.
I'm Dr. Robbie. This is Dr. Alashimi.
Nice to meet you.
And this is Nurse Dana. She's our charge nurse. We need to look over your husband.
So we see a lot of motor vehicle accidents in the ER. The things that we typically want to know up front is, was the patient wearing a seatbelt? Were airbags deployed? In the car accident, was there any intrusion into the passenger compartment? So if the motorcycle collided into this vehicle, I'd want to know if the motorcycle, any part of the motorcycle actually went through the windshield or kind of crumpled in the passenger compartment, because all of these things would make him at higher risk of a life-threatening injury. The other thing I'd want to know is what happened to the motorcyclist. Like, is that person alive? Is he dead? If the person is dead at the scene, that points towards a more significant mechanism that would put this patient also at a higher risk of having a life-threatening injury.
Open skull fracture, tubed in for agonal respirations. BP 60 palp initially started a liter of NS but lost his pulse en route.
So this is a blunt traumatic arrest. BP 66 on palp means that his blood pressure was very, very low when they first arrived, and now he's pulseless, so they're doing CPR as they're wheeling in. there are a few things that I would be wondering, like, is the patient having a brain herniation? Are there massive traumatic injuries to his chest, like a tension pneumothorax, which is when a lung collapses and air fills up and compresses the heart. I would also want to know about his abdomen. So we would be doing an EFAST, which is something that I covered in the last video, but we would be looking for free fluid or blood in the abdomen as well.
8 millimeters, non-reactive.
AKA blown pupils fixed and dilated.
So blown pupils fixed and dilated means that he's very likely herniated his brain or had a massive traumatic brain injury. Oftentimes people in cardiac arrest without brain injuries can also have fixed and dilated pupils. So regardless of if he has no pupillary response, we would still resuscitate him as if this patient is fully alive and has a great prognosis.
Oh. Push skull with tons of gray matter extravasation. At least it was quick.
So that's crazy. He has an open skull fracture and his brain is spilling out. I've seen this before when I was working in Chicago, Cook County, when a patient had a gunshot wound to his head. Typically, if brain is already spilling out, the prognosis is incredibly poor. The patient looks like he's intubated already. So the typical things that we would do is keep the head of the bed elevated at about 30 degrees so that, blood is draining out of the brain with gravity, hyperventilate the patient. Sometimes we would use medications like hypertonic saline or mannitol to decrease the brain from swelling.
No helmet?
Nope, because he took the PennDOT motorcycle safety course.
Isn't that what you took, Robbie?
All compressions, yes, but I still wear a helmet. You a donor?
He doesn't wear a helmet.
Also, no.
That is too bad. Asystole. I think we are done here.
What's next door?
The guy who...
So essentially they're calling the arrest. If the patient's in asystole, there's no meaningful heart rhythm, and the overall prognosis in a blunt traumatic arrest is absolutely dismal. So heroic measures like cracking the chest, which we saw, I think, in episode 1, wouldn't really be effective in a case like this.
Who hit him? Joy, you're with me.
What about a moment of reflection? I thought...
He'll still be dead when we get back.
As I mentioned a little bit earlier, given that this patient was dead from that car accident, this also means that there's going to be a higher chance that this first patient has a severe life-threatening injury. So all of the attention and resources should shift over to this patient. This is what we call crisis resource management, where you essentially cut your losses on the patient that has no chance of survival and place all of the attention on the patient that has the best chance of survival.
Box 99, BP 108 over 72. EFAS negative. That was a lot better than the guy next door.
How's the airway?
Good volume, good set.
So they just did the EFAS and that's negative. So that means that there's no obvious signs at this point that there's internal bleeding to his abdomen and no signs of collapsed lung in his chest.
Maybe, maybe not.
Mr. Yee. Joy, start a rub on his chest like this, really hard, please. Mr. Yee.
Sternal rubbing is what we often use to check for people's response. So right now what they're checking is the GCS, or the Glasgow Coma Scale. So it goes from 3 all the way to 15. 15 means that they have no deficits, they're awake oriented, responding to all of your commands. 3 means that they're completely comatose and not responding. So given that he's only responding to deep sternal rub, I'd want to see if his hands are actually localizing to kind of move that hand away. If he's opening his eyes, it sounds like he is moaning, so he would get probably a score around, like, I'm guessing a GCS of 7 based on what I've seen just now.
Spontaneous eye movement, response to pain, GCS is 10, borderline for intubation.
GCS
no
10.
muscle tone, flaccid paralysis.
So they're saying GCS is 10 based on that assessment. GCS 8 or less is when you would consider an intubation. So, at this point, depending on his trajectory, if he continues to deteriorate, we would intubate him so that we can facilitate further investigations like a CT scan of his brain and, investigations with blood work, doing chest x-rays, pelvic x-rays, so on and so forth.
Why is he so altered? Could be concussion, maybe a small intracranial hemorrhage.
All will be...
Intracranial hemorrhage is a bleed inside of the brain. So he's going to be probably taken for a CT scan of his head, neck, and pretty much scan from his head all the way down to his pelvis in the context of a blunt trauma like this.
Head CT will show us any brain injury, and neck CT will show us any spinal cord injury. Chest, abdomen, pelvis will rule out any internal bleeding.
There you go. They're going to do a pan scan from head all the way down to pelvis.
God, the scan should only take about 15 minutes. In the meantime, perhaps you'd let us look you over as well?
I'm fine. The medics checked me. I just want to stay with my husband.
So I would 100% recommend that we check the wife as well, just for sake of thoroughness, even if she doesn't have any obvious signs of injury, just given that 2 people have severe life-threatening injuries in that car crash, if she was the passenger, there's a very high chance that she would have had sustained some kind of injury as well.
Okay. Critical potassium level 1.2.
Wow.
Okay. Extremely low potassium with generalized weakness and no cervical injury. We may be looking at
Hypokalemic periodic paralysis.
What is that?
It's a rare condition where potassium gets shifted into the cells, causing profound weakness, just like paralysis.
Will he get better?
Yes. Back to normal in a few hours.
You know, this is so incredibly rare. I've seen 1 case of this in my entire career. And, you know, typically it would not present in the context of trauma. Typically it presents like with someone collapsing down to the ground. You know, we don't know if maybe he crashed his car or got into this accident because of the paralysis, but for him to have periodic paralysis due to hypokalemia in the context of trauma, and this is acute, I think would be quite rare and unlikely. So the way that we would treat this is by replacing the potassium with potassium chloride. So it looks like he's going into VFib. We'd start either shocking him right away if he's pulseless, or start CPR.
Starting compressions, charge at 200. What is happening?
So the patient can go into life-threatening heart arrhythmias like VFib with severe electrolyte abnormalities like this. So you'd want to now be pushing a big dose of potassium chloride. Like typically we don't push it as a big bolus or like very fast. We let it go in slowly. But if someone that's in cardiac arrest from a potassium deficit, you'd want to just slam it in as quickly as possible while you're resuscitating them with CPR and epinephrine.
potassium can harm electrical activity in the heart.
So it looks like he's in VTAC now.
Resuming compressions. Holding compressions. Normal sinus.
Carotid, strong carotid.
Oh, shit. We need a gurney. Did she vasovagal from stress?
Can't assume that.
A vasovagal episode is a reflex that happens if you see something stressful, scary, you see blood or something disgusting, and it triggers a reflex where you faint, causes your blood pressure to go low. But given that she just had a big car accident, I'd be really concerned that something else is going on.
Positive seatbelts. Oh, shit.
So she's got a seatbelt sign, which is bruising to her abdomen from the seatbelt. What that means is that the amount of force that went through the seatbelt is strong enough to cause capillaries in your skin to actually leak out. And that makes you at much higher risk of internal organ damage, like damage to your spleen and rupturing of your bowels. So she would definitely need to get a CT scan for this kind of presentation.
Hang 2 units of negative the rapid diffuser. Somebody call Garcia.
Shit, we really should have insisted on examining her.
Okay, I got the head.
They should have.
Platelet and BP 84/56, heart rate 112. Free fluid.
So they're doing an EFAST exam right now, and from that quick glimpse, I could see that there was some free fluid in the abdomen.
It's much bigger than before. She's not turning the corner. OR's holding a room. I'll let the husband know.
Where's Nancy? She had an injury to her spleen right about here.
Oh, it's her spleen.
Internal
There you go.
Oh, God. You think things are important? That everything's so important? And then you end up here and see.
That's a really profound thing for him to say. Everyone thinks that they have so many issues in life until they have one issue, and that's their health. And nothing else seems to matter at that point.
Yeah, that is how it works.
The overall theme of this episode was the interpersonal dynamics and raw human emotions that we see firsthand in the emergency department. And I thought they did a really good job showing how those emotions kind of play out on us as the health providers, and how we actually have to de-escalate a lot of these situations. I'm really excited to see what happens in the next episodes, but if you found this YouTube reaction educational, insightful, or entertaining, please give it a like and support this channel. Subscribe for more, and I'll see you in the next one.